Morning, everybody. It is week 5, and this is our first double or 2-unit CVPP lecture. Here we go. All right, we were talking about aneurysms. We pretty much finished abdominal aortic aneurysms. Now let's talk about some other kinds. We have to talk about the Berry aneurysm, right? Boards love this one. Everybody's got to know about Berry aneurysms. So this is pretty high yield material. We talked about the different types of aneurysms. Berry aneurysm is not usually a fusiform aneurysm. It's a saccular. Remember, saccular aneurysm was a focal outpouching from a weakness of a blood vessel wall. And why do we care about Berry aneurysms? It is the most frequent cause of clinically significant subarachnoid hemorrhage. In other words, if you're going to have a bleed in your brain and it's going to cause some neurological stuff, sequelae, it's probably going to be from a Berry aneurysm. Right? It's also the most common type of intracranial aneurysm. Almost always occurs in members of the circle of Willis or in a region very close to the circle of Willis. The aneurysm is typically considered congenital because you are born with a weakness, right? So it's secondary to a congenital defect in the vessel wall. So the place where the aneurysm occurs, why there's a focal weakness in the blood vessel wall, is because there's actually an absence of tunica media for whatever reason in that region. And the internal elastic laminae is gone. So that's the internal and external elastic laminae gives some good strength to the vessel wall. So it's missing the internal. And then it's completely missing the tunica media. So it's pretty easy for it to start bulging out because that section of the blood vessel is quite weak. It just can't handle the pressure. Right? I think we better review the circle of Willis. So AKA is the cerebral arterial circle. Kramer calls it that. It's a board book. It's also called the circulus arteriosus. Okay, you could probably figure that out. You should know those. Don't know which one I will put on the test. And its form, here's a great question. It's formed by two arterial systems coming together. Who are those two systems? I can see the question now. The blank and blank arterial systems come together to form the circle of Willis. And then I could have different choices. And the correct answer would be the vertebral basilar system and the internal carotid artery system. All right, and we're good with that. And that's from Drake. That's your student Gray's Anatomy. That's a board book. Where does it live? So it lives, remember the anterior, middle, and posterior cranial fossa. Those are like the steps, the 3 steps of the kind of the base of the skull, or the base of the floor of the skull, so to speak, where your brain sits. It lies in the middle cranial fossa. And technically it's within the subarachnoid space. The dura is on the outside, and this is on the inside. So it's in the subarachnoid space. That's why if you get a bleed there, you get a subarachnoid hemorrhage. Specifically, it's found surrounding the clivus, sella turcica, and optic chiasma. Okay, now this is not 3-dimensional, but remember this is a kind of a shot of the floor of the cranium here. And we have this as the anterior, middle, and posterior cranial fossae. So this one's higher, this one goes down a notch, and this one's the lowest down here. But it lives right in this area, right? Oh, you can see it right here. Most of it. lives right there. All right, and there's the clivus, right? That's the part of the body of the sphenoid. Remember that from gross 2? And there's kind of the occipital portion or the basilar portion of the clivus. Selaturska pituitary would be right down here into the plane of the page. Anterior clivus right here. What's that? More specific. You said sphenoid, I heard you. Lesser wing of the sphenoid, greater wing of the sphenoid is a little bit deeper down here. All right? So there it is. There's the parts of it. And here's the internal carotid artery coming around right there. See, it goes underneath. And that's the end of the internal carotid artery right there. And we'll see in a minute how that's the middle cerebral artery. That's the anterior cerebral artery. That's the end of the internal carotid artery, splits into those. Middle cerebral artery is not part of the circle of Willis, but the anterior cerebral artery is. All right, but that's the, so this is all called the part of the carotid artery circulation. Then we have the two vertebral arteries, the basilar artery, and that's the vertebral basilar system, which gives rise to it in a second. I mean, I could go over there, but we'll go over that in a second. Here are the members. I usually throw a question, maybe every other quarter on this. Who are the members? Which one of the following is not a member, or blank is not a member of the circle of Willis? So we just talked about the basilar artery was formed by two vertebral arteries. Well, I'll show you the picture. Let's go over these when we get to the picture. I always like this picture. So here's the basilar artery, and if you want to blow that up to get your bearings, foramen magnum, vertebral arteries come together. There's the basilar artery right there. So we're going to blow that area up. Basilar artery dead ends and splits into this dude right here. That's the posterior cerebral artery. Posterior cerebral artery gives a big branch right here. And we're going to talk about this. This is clinically significant. This is the posterior communicating artery, one on each side. See, it's starting to make a circle. Then it's going to dump into that's going to connect to the internal carotid artery. Internal carotid artery is going to this. They didn't quite do this one. Really, the posterior communicating should have. See how the posterior communicating, it dumps into the internal carotid artery usually. And then the internal carotid artery right underneath here keeps going. And then it splits into the anterior and middle cerebral arteries. So this picture's a little messed up here. Kind of a confluence area, though I'm sure it could be so in some people. Nevertheless, there is the anterior cerebral artery right here. I think we went on this side in blue, but that goes all the way up here. And then there's a communicating branch between the two, and that's called the anterior communicating branch. Right? So we just have formed a circle of blood flow, and that's how blood gets from the basilar system into all these different parts of the brain. So it's very important. This supplies a whole bunch of brain tissue. Right? I was going to say, take a look at this right here. It's been cut, but notice how remember the oculomotor nerve? We talked a lot about that in gross 1. Or was that gross 2? That was gross 2. I think I talked about it. No, gross 2 it was. Anatomy. But notice how they travel side by side. What happens if you get a aneurysm coming right off here? Let's draw it back here. See how it can push into the oculomotor nerve? And it can cause oculomotor nerve palsy. That's a big problem. Aneurysm's right here, off the kind of the end of the common carotid artery, where it bifurcates. These aneurysms usually occur where these arteries connect, kind of weak spots there. But you can see how that can affect part of the vision, right? It knocks out the nasal field, ipsilateral nasal field. That's kind of where we're going on that. All right. And there's a little more specific if you want to. Everything I just said, you can read about that. Not very many stars. Are there any stars on that? That's probably not, won't be. but I sure do want you to know the members and everything I pretty much said about this system. All right, that's just where I blew up. So here's remember the internal carotid artery? It does that. They didn't show it, but it does that kind of a loop underneath the anterior clinoid, and it comes back around. So that is internal carotid getting near its end. It goes underneath that one, and it's right there. That's the end of the internal carotid artery, and then it splits into that anterior and middle cerebral arteries. That's always a confusing piece of anatomy. There are variations in this thing. In fact, very rarely does it look exactly like that. There's just like when we talk about the heart, there's a right-handed and a left-handed coronary artery system. There's also a right-handed and left-handed circle of Willis. And one side is usually more developed, and the other one is still working, but it's smaller. Kind of more used for backup. Because it is a circle, blood can get to both sides of the brain if either side becomes blocked. So we'll take a look at that in a second. But here's all the different variations. Some of the cerebral arteries and communicating arteries may be absent or may be doubled. We'll see a case of doubled in a second. So it can be quite anomalous, and if it is anomalous, it is thought to increase the chance for bleed or aneurysm. What do you make of this? Let you study that for a second while I open up my water. Can you even see where you are? Well, this is a 3D CT reconstruction. Here's foramen magnum. Down there. I guess it doesn't show up there. There's the clivus right there. So this is the circle of Willis. So the basilar artery is kind of off center, and it splits into the posterior communicating branches. But look at this one. We got a double, right? There's two of them. So yeah, what else? Somebody saw it. See a problem here? Yep, right there. So internal carotid is coming right there, kind of splitting into its pieces. There's the anterior cerebral, which is having some trouble, right, compared to the other anterior cerebral. This is a aneurysm. It's a Berry aneurysm. Run of the mill, and that's a pretty good size one too. This has definitely got to worry about these. Okay, so all kinds of craziness there. About some fun facts about Berry aneurysms. It's not like Marfan's syndrome, right? Marfan's is 0.01% of the population. 2% of the population has these. Luckily, most of the time they're asymptomatic. Well, luckily or unluckily, the first symptom you may feel may be your last symptom. But much more common than, way more common than the dissecting aneurysms we're going to talk about in the vertebral artery. They usually occur in the anterior circulation, right where, what is the anterior circulation? I forgot to tell you the anterior circulation. So the anterior cerebral artery and the anterior communicating arteries. That makes up the anterior circulation. And most of these things occur right at these junctions. Right. Where's that one? Is that in the anterior circulation? Absolutely. All right. If you see one, a lot of times there are more. Let's see if we go back to this. Wasn't there another one here? Looks like we got one right there. Big one there. Looks like we got one down here as well. So about 25% of the time, if you see one, you're going to see others. Here's a classic old, I don't know, this is from, I forget where this is from, but most of them, 40% of them occur right up in here or in the junctions. I mean, they should have put that one over here because that's part of the anterior So 60% of them occur in the anterior circulation. You can get the middle cerebral artery splits into a couple branches, temporal, parietal, etc. Right where these splitting points are, they can occur there as well. Fun facts. So after the diagnosis, if it's a small one, if it's under 10 millimeters in size, what happens? I mean, if you see one, you're going to get it. If it's a small one, you will have to get follow-up MRIs to keep an eye on it with contrast. What happens a year after you have chronic headaches maybe, and you go in and they do an MRI with contrast, and yeah, you have a small, maybe a 5 millimeter Berry aneurysm. What's going to happen by the next year when you come back for your follow-up MRI? Pretty good. About 1.3% of those will have ruptured. We'll look at the rule of thirds. When a rupture occurs, a third of the people die, a third of the people become severely impaired, a third of them make it okay out of it. But if it's over 10 millimeters, that's when you got to do something about it. Greater than 10 millimeters, next year, if nothing's done, 50% of them will be dead. And this is a really tricky area, right? They're trying to get stents in there to protect it. It's pretty tough to get, if not impossible, to get anything around it. So it's really tough. You got to lower the blood pressure and just avoid constipation like that. Avoid anything that will increase the pressure within the arteries like that, squatting. I saw this yesterday. A girl squatted 603 pounds in 2017. I didn't realize there. And that was, I think, in the 220 weight class. I think the record's even higher for the bigger weight class. I didn't look what it is, but that's quite an amazing squat. Although how much guys squat? Guys are up, I believe the record's over 1,200 pounds. But nevertheless, that's a tremendous. But you can see, look at the jugglers. Tell me there's not some major pressure going on in the pipes. I mean, if you're a weightlifter like this and you haven't blown a pipe, you're probably pretty safe as long as you don't get some infection. Your pipes have been tested. Anyway, high-risk activities, about a third of the bleed events. When I say rupture, I mean a hemorrhage event. And that if it hemorrhages, it's a what? It's a subdural, it's a subarachnoid hemorrhage, subarachnoid bleed. A third of these things occur during events that raise your intracranial pressure. It doesn't have to be like this crazy. It could be just regular other sporting events, constipation, you're pushing to get the fecal material out, weightlifting, intercourse, orgasm, right? There's pretty high pressures in that as well. So here's the rule of thirds. I do typically ask a question on this. What happens if you do bleed? One springs a leak. You get a subarachnoid hemorrhage. 33% dead. Hit the floor and never come back from a massive subarachnoid hemorrhage. And we'll look at why, kind of the domino effect blood in the subarachnoid space has. 33%, they become unconscious, and that's a really bad sign. They wake up and they maybe wish they were dead. They have severe permanent neurological sequelae. Not all of them, but some of them. It all depends. Now, if they can stay conscious and not pass out, that's usually a good sign. And that means they do fairly well, but they are at risk for another bleed. Classic signs of a bleed, I do usually ask this question. Excruciating 10-10 headache. Severe pain. Now, a migraine headache can mimic this. My wife actually gets these things. And the first one she got when she was probably 55 or so, I was scared to death. I thought she had, I've never seen her in so much pain. She's vomiting and horrible headache. Turned out to be a migraine, but the migraines can fake you out. She had nausea and vomiting. She didn't have double vision. She did have photophobia. Had to keep the lights off in the ER. But here's the difference. She didn't have any neurological deficit at all. So that made me breathe easier. Some can go into a seizure. So focal neurological deficits are kind of the one thing that sets it apart from the migraine patients. Migraine patients can have auras. They can have double vision. They can all kinds of weird things. They don't usually go into seizure either. All right, so why are these subarachnoid hemorrhages, and not just of Berry aneurysms, any type of subarachnoid hemorrhage? Well, if you get into the subarachnoid space, I mean, the blood can travel around, and there's a lot of blood vessels kind of on the inside of that subarachnoid space that communicate with it. And we're not 100% sure what the deal is, but we do know that the presence of blood contacting another artery, there's nothing wrong with this other artery. It's fine. But it causes the endothelial cells to release endothelin, which is a powerful constrictor, right? It's a vasoconstrictor. And it will cause a spasm, almost like Raynaud's type phenomenon. Causes a spasm of that artery. That has nothing to do. There's nothing wrong with it. It's not bleeding, but nevertheless, it can go into such a spasm from the irritation of the blood that it knocks out a huge part of your brain. That part of the brain that it feeds no longer gets blood, and you get a stroke from that. And you get a stroke from the one that's bleeding because the blood vessel that's popped, the tissue downstream isn't getting, it's like a beaver dam. It's not getting blood. So that tissue dies, and then adjacent tissue can die because of the negative effects of blood contacting other blood vessels. Carotid arteries and visual field disturbances. Now, how in the world could this... Well, I kind of gave it away, though, didn't I? Because we know part of the posterior communicating branches are right next door to the oculomotor nerve. And the optic chiasm is right next door as well. So you certainly can get, and maybe that could be the first indication of a bleed, is visual field disturbances. So we need to go through those. So here is the one I tried to draw before. A very common anterior circulation. Berry aneurysm. This one's occurring at the communication where we're kind of right in the confluence here. There's the anterior cerebral right here. So this is the junction. Where's the middle? Oh, I see. They have the internal coming way back here. I mean, this wouldn't be here, right? That would be looped up coming around. This is terrible. I never realized this, but this should be going that direction, right, as the middle cerebral artery. It doesn't keep going like that, so I'll have to try to Photoshop that one out of there. But nevertheless, the point of this is it's irritating this lateral part of the optic chiasm. And if we follow that down and see where that goes, here's a cartoon of it, but there's the Berry aneurysm. And if you knock out that lateral tract, that supplies the lateral part of the retina. But remember, the lens crosses the light. And so this actually ends up causing a nasal field visual disturbance, like fuzziness or maybe black, depending on how bad it is, maybe little dots. There's some kind of weirdness going on, not to the periphery, not to the lateral part. It's okay here. But it's that nasal field. Why do they call it nasal field? Because there's your nose right there. All right, we good with that? And this is, I'm not going to test you on this, but you should definitely know all these. I'm sure you had this in neuroscience. You got to know what defects here, what type of visual field disturbance do you get. I won't hit those. We talked a tiny bit about the posterior communicating artery that could compress and inflame and damage the adjacent oculomotor nerve if it's lateral, if the aneurysm is lateral. And therefore, you could get oculomotor nerve palsy. What is that word anyway? The sidetrack. What does palsy mean? When you see palsy, that word is only used if a cranial nerve is involved. That's the only time you ever use palsy. It could be paresis or paralysis. Paralysis is whatever motor portions go, or that nerve is just paralyzed. It doesn't work, period. Paresis means it works a little bit, but it's dysfunctional. Okay? So paralysis is a complete loss of function, not only movement, just function. Paresis is an incomplete laws. All right, so there's the little cartoon. I do like to fall down this rabbit hole because I've learned you guys are not the greatest on this stuff. So here is the posterior communicating artery, part of the circle of Willis, and there's an aneurysm. And there's the oculomotor nerve. So if we blow that up, you can see we've damaged some of the axons of the oculomotor nerve. All right, that's cranial nerve 3. So what's the sequelae of that? Well, if the oculomotor nerve is damaged and not working, it's going to impair the things that it controls. And the oculomotor nerve is very busy, right? It controls many of the extraocular muscles that we saw in gross 2 anatomy. So who's knocked out? Superior rectus is knocked out. Inferior rectus, medial rectus, inferior oblique. So, or you could look at it as who's not affected by an oculomotor nerve palsy. Well, the superior oblique, who's that supplied by? That's the trochlear nerve, right? Cranial nerve 4. And then lateral rectus, who's that supplied by? That's the abducens nerve. You got to know your cranial nerves. You cannot escape not knowing cranial nerves. And then I could ask, you see all the stars. I love this stuff. This is kind of my chance to do a little neurology on you, a little neuroscience. See if you remember. Superior rectus, 2 main functions are to lift the eyes up and in. So to elevate and abduct the eyes. Inferior rectus, in or down and in. Medial rectus is easy, just turns the eye, abducts the eye or turns it inward. Inferior oblique, the obliques are the weird ones, right? It turns the eye outward. You think it would go inferior, but it doesn't. It goes up, the opposite of what you think. Right? Therefore, a patient with a oculomotor palsy problem or an injury to the oculomotor nerve, they typically can still turn their eyes outward and downward. They have plenty of power to turn it out. All right, because inferior oblique is out, but we still have lateral rectus as a powerful. Abduction is out. Adduction is in. So erase all that stuff I said. Right? Abduct. That's turn the eyes out. I always think where are your adductors? They're on the inside. They squeeze together. Deduction is to turn the eye nasally inward toward the nose. So that's superior rectus adducts. Inferior rectus also adducts. Medial rectus purely adducts. Sorry about that. This outward is abduct. Inferior oblique abducts and turns up. But you'll still be able to turn your eyes out because lateral rectus abducts like crazy, even though you lose a little bit of power there. And you can still turn it down because superior oblique turns it down. Okay? See how all that works? Questions coming. Your CCP exam typically has common stuff like that, so you do need to know that stuff. So what else? You guys usually remember that, but here's where you start getting fuzzy, I think. Let's not forget that the oculomotor nerve also controls another really important muscle called the sphincter pupillae, or singular is sphincter papilla muscle, collector, plural is papillae. And then the ciliary muscle, that's the muscle that can make the lens fat for near vision or make the lens relax and thin for long vision. Those are really important. So if you have a cranial nerve 3 lesion, let's say on the right side, how will the direct light reflex be on the right side? Because the cranial nerve comes back. Remember, it comes back on the contralateral and ipsilateral side. So the direct light reflex will be shot because your pupil can't close. It's damaged. You shine your light in your right eye, and there's a lesion of the right oculomotor nerve. You'll get no reflex miosis or no pupillary constriction. So you'll have no direct light reflex. However, what about the other side? The other side will be fine, right? The contralateral side will be fine. So you'll have an indirect light reflex. Right? So your left eye will be functioning okay with regard to the direct light reflex, but you'll have no direct light reflex on the same side of the lesion. Got it? All right. Now, if you're testing the left eye and they have a lesion on the right, they will have no indirect light reflex, but they will still have a direct light reflex because there's nothing wrong with that eye. There will be no accommodation reflex, however. We'll look at that more specifically here in a second. I probably should have just jumped over here, but let's do that again. So let's say we got some type of tumor and it's pushing on this oculomotor nerve. Let's look at what happens when you shine a light in your eye. So we're testing I guess that's the left eye, right? So the light goes in. What's the afferent limb? You need to know that word. There's an afferent and efferent limb. That just means the wiring. Afferent is going into the brain. So the afferent limb is actually cranial nerve 2 here, which we know is the optic nerve. Right? So there's nothing wrong with the optic nerve in this scenario. That takes the signal in, it splits at the optic chiasma, and it's split into 2 pathways. So the pretectorial nucleus receives this information. Edinburgh-Westphal nucleus relays it back. So now it's coming back double. It went in on a single afferent limb and then split in the brain, and it's coming back on 2 wires. These are called the efferent limbs. Efferent limbs. And those are our ocular motor nerve. Right? So if the lesion is here, the signal gets blocked right here. So this eye is messed up. But there's nothing wrong with this eye. Everything will be fine. Accommodation will be fine. Accommodation reflex will be fine. Everything will be fine. The muscles will be fine of the eye. But this one is messed up. With regard to the direct light reflex, pupillary sphincter, or what? Sphincter pupillary muscle, sphincter pupilla muscle, sphincter pupilla muscle is messed up. That's the muscle you need to close your eye to constrict your pupil. So that won't work. You shine a light in this eye, the pupil stays the same. Nothing happens. However, as you look over at the other eye, that one constricts. Why does it constrict? Because the light reflex is working the same. This still works. So the indirect light reflex is over here is normal. The direct light reflex is screwed up. Right? Everybody understand that? Now what if we test this eye? Okay, these are classic questions for medical boards, PT boards, chiro boards. Everybody's got to know this stuff. Acupuncture boards. You got to know this stuff. So if you test the right eyeball here and there's a lesion with the left oculomotor nerve, what happens? Well, the signal goes the same, goes up the afferent limbs, cranial nerve 2, no problem. It splits, comes back double power. There's no lesion on this side, so the direct light reflex will work. Accommodation will work. Everything works. The muscles are fine. Everything's fine on this eye because there's nothing wrong. The problem now is going to be with the contralateral eye. There'll be no direct light reflex. There'll be no accommodation over here. Right? Everything that cranial nerve 3 operates. Might even be a little ptosis going on, depending how bad the lesion is. All right, so see how that works? You got to understand that. So play that back. Make sure you understand that. All right, this is pretty much everything I said. But let's talk about this, because there's another thing you guys don't understand. The accommodation reflex. This is Jong. It's a big, probably the best neurology book, I think. I think it's a medical board book. We don't use it. But nevertheless, it explains things much better than our books do, I think. So here's the deal. Accommodation reflex is three things. Right? There's three parts to the accommodation reflex. It's not just one. It's not just take your finger from afar and bring it to the patient's nose and watch their eyeballs cross. That's much more to it than that. That's only one of the parts. So let's look at that. And all of these occur when the patient focuses his eyes on an incoming object. An object like a finger, or it's better that you use like a pen with some writing on it. So you can move that from far away and bring it right toward their nose and have them focus on that pen. Why writing on the pen? Because then they can read it. We can check to see if that lens is able to fatten up or not. All right. It's testing. Cranial nerve 2 again is the afferent limb. Cranial 3 is still the efferent limb. All right, so the procedure, patient focuses off into the distance, maybe your finger or pen way away, and you bring your finger with some writing on it and move it toward their nose slowly. The doctor is going to watch for two things. So the accommodation reflex, there's two objective parts to it, and then there's one subjective. You have to rely on the patient telling the truth. But you're going to watch for something called convergence of the eyes, or that's making the eyes cross. If both eyes can deduct, come inward, then we know cranial nerve 3 must be intact, right? If they can both eyes cross inward, that's awesome. Convergence is okay. That test was normal. Also, you can watch the pupils as you bring the finger closer to the eye. So here's a finger way off in the distance, and then you got light bouncing off that finger. But if you bring that right up to your nose, the finger's much bigger, and there's a lot more light bouncing off the finger and getting into the eyes. It's like someone shining a light in your eyes. And therefore, both pupils should constrict. That's meiosis. That's what I like to call mitosis and meiosis, because you get meiosis. If you call it mitosis and meiosis, here's another meiosis. So that's why I always say meiosis when we're talking about gametogenesis. All right, so we good with that? So you have to, the third response, this is the confusing thing. It's called the accommodation reflex. One of the three components of the accommodation reflex is the accommodation response. Okay, so accommodation is part of the accommodation reflex. That's confusing. This is where you ask the patient, are you able to focus on the finger? If you have a pen, can you read a single word on the pen? And then in order to see the finger up close, they have to thicken the lens. And they have to, in order to do that, there's some muscles that have to be relaxed. You have ciliary muscles, which, do I have a picture of those? I guess I don't. We saw those before, though, right? I showed you those with Marfan syndrome. Those cords that attach to ciliary muscles can break. So when you're reading, to fatten the lens, you have to contract the ciliary muscles, which allows the lens to relax and go back to its skinnier shape. If you relax the ciliary muscles, the lens fattens up, kind of the opposite of what you would think. All right, so we good with that? So normal response, convergence occurs, meiosis occurs. Here's another way to pronounce it. It's meiosis or meiosis. Anyway, both pupils should constrict, and the patient should accommodate. They should be able to read something close up, or at least focus on something close up. That's my dragon. Should be other meiosis. Oh, no, that's right. Let's talk about another thing that can happen. Now this doesn't always happen. There has to be really bad paralysis of oculomotor nerve for this to happen. But the oculomotor nerve, here's the eyeball, right? There's the lens over the eye. Here's the eyelid. But remember, we have a couple of things. We have muscle, orbicularis oculi. The palpebral division is right here. That doesn't say that, but that's palpebral division. That's over the eyelid. That holds the eyelid open. There's another muscle that we learned in Gross 2, levator palpebrae superioris. That's also cranial nerve 3 muscle. That also helps hold the eye open. So that's one problem. If you knock out this muscle, you're going to get a little droop of this eyelid. It's going to droop down to here, right? And that's called ptosis. There's another muscle that connects called superior tarsus or superior tarsal muscle or Mueller's muscle or Muller's muscle. Different way to say that. This one is not controlled by cranial nerve 3. This guy is a sympathetically controlled muscle. Specifically, you remember that superior cervical sympathetic ganglia, that big ganglia I showed you in first quarter? Was that first quarter? That was first quarter. That muscle or that ganglia has fibers, and it doesn't even have to be the ganglia, but there's sympathetic ganglia from that whole cervical chain that run and give power to this superior tarsus muscle. You get something like a Pancoast tumor and it compresses that ganglion, or you get some tumor in your neck that compresses the sympathetic chain. You can knock out this muscle, and then same thing's going to happen. You're going to get a sagging of the eyelid. Okay, that's another cause of ptosis. What's another cause? Well, what if you get Bell's palsy, and you knock out the cranial nerve? Does that say that? I don't know why that's there. That I got to fix that for sure. That should not be there, because we know that's not cranial nerve 3. Let's see. That is slide 634. Fix. Cranial 3, no. Yeah, that's facial, right? That's the facial nerve, I believe. Or is that? Well, we'll see when the slides come. But yeah, if you knock that muscle out, that's a really bad one, because then you get a really drooping of the eye even further. Maybe not that far, but the other thing is, remember that muscle on top of your skull, the occipital frontalis muscle? That's anchored into the orbicularis oculi. So if you have a paralysis of orbicularis oculi, it actually relaxes. This muscle goes back because this overpowers it. There's nothing to attach it here, and your whole eyebrow goes way up. Now, it's called brow ptosis. So that's another thing that can happen. But let's go through this now. So ptosis is from a palsy of levator palpebrae superioris. And there's Horner's syndrome. We didn't even talk about that. I'm not going to go getting too far into neurology now. It's another cause of ptosis. But ptosis from a palsy of levator palpebrae superioris can occur from oculomotor nerve injury. In layman's terms, they call that a droopy eyelid. Right? Muller's muscle or superior tarsal muscle is another, also supplied by sympathetic. So that will be working. Right? So your eye's not going to completely droop. But if you have a injury to the sympathetic, superior cervical sympathetic ganglia or cervical sympathetic chain anywhere, if there's compression, that muscle can be out, and you can get a slight ptosis from that as well. Okay, like a Pancoast tumor is notorious for doing that. A third cause is a facial nerve. palsy of facial nerve. That's called Bell's palsy. That can also knock out the orbicularis oculi and cause a massive ptosis called a brow ptosis. As I said, the orbicularis oculi helps anchor down occipital frontalis muscle. And without an anchoring, it contracts, as I showed you before, and it raises your eyeball. Here's an example of a brow ptosis. This is pretty serious ptosis, right? It's much more than that. We can still see some eye there. But Bell's palsy people, it's much more serious. And look at the eyebrow, right? This one is down here, but there's nothing anchoring the frontal fibers of occipital frontalis. So the brow gets pulled up that way. Okay, see how that works. Here's another slight ptosis. So this is a Berry aneurysm patient. See, it's not nearly as bad as that, the brow ptosis from 7. Why? Because only that, oh God, my brain's going. Levator palpebrae superioris is affected here with this one. Okay. All right. Out of the rabbit hole. I'm sure they taught you that well in neuroscience, but if they didn't, make sure you know that stuff. There's a patient who died, and they did autopsy, massive bleed. You can see the blood all over in the brain, and there, right at the junction there in the anterior circulation, is a massive Berry aneurysm. Okay, there are some associations with Berry aneurysm. Cigarette smoking, hypertension. In fact, 50% of Berry aneurysm patients have antecedent hypertension, pre-existing hypertension. Atherosclerosis, congenital weakness. That can remove that. That is, why would I say that? Congenital weakness, it is congenital weakness, right? Let me get rid of that. Still amazing when I talk to you guys, I'm like so much more focused on these slides. I catch these little tiny errors that have been in these slides for a long time. It's something about the YouTube. I can slow down and relax. Fix. And an embolism. So other causes, associations are lodged. These are causes, though. These aren't really associations, so I think I can get rid of both of those here. Some other associations are risk factors for the development of a Berry aneurysm, or maybe that's what I was trying to say there. An embolism, if it gets stuck, it can stuck downstream. It can cause increased pressure. I think that's what I was trying to say there. But the connective tissue diseases, Ehlers-Danlos, neurofibromatosis 1, Marfan's-Lewis Dietz, coarctation of the aorta, which we haven't talked about, but we will, also increases the chances of Berry aneurysm. All right, let's start vertebral artery dissections. Normally we would be taking a break right now. And here we go. So before we talk about vertebral artery dissections, let's review the vertebral artery. Remember, there's 4 parts to the vertebral artery that you should know. V1, who's this vessel right here? Oops. Who's that vessel? Subclavian, left subclavian artery. Remember, we get a big branch. That's called V1, or part 1 of the vertebral artery. That jumps in. Remember, it misses C7. This is C7. That's weird. Most of the time it misses. The vein goes through there, which isn't shown. But there it changes name. So V2 goes all the way up to C2. V2 and C2. But once it comes out of the transverse foramen, as it peeks its head out, right there, that's V3. So V3 comes out of C2, transverse foramen, goes through the transverse foramen of Atlas, does this crazy hairpin turn. It goes through the groove for the vertebral artery, right? That's covered by the posterior atlanto-occipital membrane, we'll talk. Oh, that's right. We're still going backwards in spinal anatomy. We haven't talked about posterior ponticle yet, but you'll learn more about that in a while. And then once it goes in the thecal sac, once it penetrates the thecal sac that runs down, like if you had X-ray vision, you could see it. Then it becomes V4. So this part isn't as strong as the other parts too. This is a kind of trouble area sometimes. All right, there's another nice picture of it. Crazy bend there, right? You can imagine plaque building up right in this region. And there it's just showing how it penetrates. This is anatomically incorrect as well, because the penetration of the posterior atlanto-occipital membrane should be back here, because there's a groove that it runs against here, so the author messed this up completely. But then it penetrates, once it penetrates the dura mater, then it becomes V4. So that's nice. All right, so what's the problem with a vertebral artery? You can have dissections, and they can lead to aneurysms. You could have aneurysms, but usually dissections is more of a problem. And the aneurysm usually forms from the dissection. So there's two ways that this can start, just like, this is very similar to the dissections we've talked about. You can get a rip in the tunica intima, and the blood can start working its way into the tunica media and stop, and then rip downwards, right? Oh, I don't have to draw this again, do I? So if the blood goes through the tunica, here's the tunica media of the vessel. I guess we'll make this bigger. So the blood rips into here, and it stops, and then it rips down or rips up the flow of blood. And that's a dissection of the vertebral artery, just like we've talked about before. So is this a true or false aneurysm? If it forms in it, it would be a false aneurysm, right? Because true aneurysms are just a weakness. There's no ripping of the tunics. The other way is a vasovassorum. And I think I said when I talked about the aortic dissections, they tend to happen more here in the vertebral artery. So more common, these vasovassorum dissections are more common than the regular old rip the tunica intima type of dissection. Right? The sequelae are exactly the same. So we got a false lumen that can fill up with hematoma, and it can push into the true lumen, just like when we talked about the aorta, and you can start to get a decrease in blood flow, especially if it hasn't double-barreled yet. And that's not good, because that's a major pipe going to your brain, supplying the brain with blood, so you can start getting ischemia and confusion and visual problems and some of the early signs of this stuff. So that's one problem, but probably the biggest problem is double barrowing. Remember we said when the, back to my terrible drawing skills again. There's the tunica intima. Here's the tunica media. So we got to rip through the tunica intima. This is the lumen here. There's the blood vessel going down. There's the tunica intima going down. So when the blood gets in here, it doesn't aneurysm out, but it starts going down. So the blood starts backing up in here. This blood, it could stay like this for a long time. This blood could clot and cause all sorts of hard little balls of blood here. It can also start to bulge this in, right? If the clot really gets bad here inside, that causes luminal stenosis. And there's, I guess, we'd be going this way toward the brain. But it can start to beaver dam this. But the problem is, if this goes back, rips in to the lumen again, I kind of went the wrong way. But you can get all these pieces, these bombs, just like I showed you before. You get all these blood clots flying up into the brain, and they're going to get stuck as the circulation gets smaller, and you're going to have big areas of tissue death and brain death. You can have a stroke from this. Right? Here's a case I worked on a while ago, involving a chiropractor. And they had a hypoplastic vertebral artery. So look at this is the left over here. Oops. Here's the right. So look at the size, and this is an arteriogram where they injected contrast into arteries and did a CT scan while they were filled up with contrast. You can see a pretty good size of it here. Okay, it's getting tortuous up here. This is just one slice, so it goes out of the slice. There's nothing wrong here, but look at this side. So this actually turned out to be, all in here was a big dissection. And see how the lumina is very decreased. That's a beaver dam, right? And here, it actually really, really severely decreased there. And so, yeah, the person ended up having a piece of, probably what happened is they probably double-barreled the artery from a manipulation, from the force of it. And it can be not just chiropractic. I mean, it could be working overhead. There's other things that can cause it beside manipulation. But a good, strong chiropractic manipulations, in my opinion, it's enough force to certainly jar loose a piece of plaque and send a bomb flying up here. And that's what happened to the patient. Had a stroke because of that. Sad tale. There's more to the story, but I won't go into that. Genetics can be a risk factor. So mom and dad have one of these things. You have to be more careful. The connective tissue disease patients are at risk for getting one of these dissections. Now, a precipitating event, chiropractic manipulations are usually the precipitating event. It's kind of the straw that broke the camel's back. If you have, heaven forbid, here comes my drawing again. Here's the tunica media, or tunica intima going up. Here's the noodle up here. There's the brain. This is just like a ridiculous cartoon. Here's the tunica adventitia. So if you get a dissection here, this is one thing that can happen. So the dissection fills up with blood. The same thing I just told you. Right, and we get clots here, and everything's, but especially if it's one of those vasovassorum where there's not as much pressure as this. So this is all clotted up. Maybe you get a little beaver dam here, but no big deal. But this thing is not double-barreled yet. If you do a chiropractic manipulation or any other type of wrestling or any other type of extension, lateral flexion, and rotation at the same time, George's test, right, is a test we used to do. But whatever, if you get a force enough, you can rip open, you can double barrel the aorta. And now we have these big bombs, those blood clots, the same thing we've talked about for the abdominal or for the ascending aorta or any part of the aorta. You get this train of emboli going up into the brain, and it can kill the patient. But the precipitating event is the force needed to double barrel the aorta. Or what if you have, because here's the other tunica media, what if you have just a whole bunch of atherosclerotic plaque formation here, right? And you manipulate the neck real hard. You could break a piece of that plaque loose, and the same thing could happen. That's another mechanism for stroke, right? Super rare, though, as we'll see. So don't freak out about it. It's very rare. Much, much, much rarer than Marfan syndrome. Although there's controversy about what the prevalence is. But you can tell, you can ask malpractice insurance companies. It's a pretty rare event. It doesn't happen that often. All right, so what are some of the precipitating events? Anything that hyperextends or puts the neck into extension, tilts the head back, tilts the head to the side, ear to the shoulder, and then rotates the head. Could be to the same side, could be away, but any of these maneuvers, and maybe just hyperextension, somebody putting in putting in can lights in their house in their head, or painting the ceiling. Just sometimes the extension and rotation combination is enough to jar something loose. So of course, the one that gets all the press is the spinal manipulation. You don't hear when it's painting overhead work, like painting your ceiling or putting in fans or can lights or something like that can happen just as easily. Maybe not quite as easily because you're actually putting a thrust with spinal manipulation in addition to kind of setting up the bone in these with these type, like lateral flexion is used. Not so much extension is used, but lateral flexion, rotation are used in many manipulation procedures. Yoga position. So all of these are kind of the straw that broke the camel's back. Other precipitating events. So anything that increases the pressure in the pipes. There's our squatting again, Valsalva's type maneuvers, constipation, orgasm, weightlifting. Those can all pressurize the pipes and may cause a double bearing or a piece of atherosclerotic plaque to break loose. Here's just a little research. I haven't checked this for like a year or so. But chiropractic is associated. There's plenty of cases. Park is one fairly well done paper. Chen, there's a bunch of papers out there on this. So what do we know about it? So if you look at Park, about 1 in every 20,000 spinal manipulations, grade 5s, I would take it. Like the crack, not so much the activator. I don't see how an activator could possibly do this, but physically putting a force into the cervical spine. Prevalence is, Marfan's was 0.01. This is 0.005 according to Park. But there's other research that shows it's even more rare than that. There's one paper that showed it was 0.00005. So Chen, in the Chen paper, this is ridiculous, but one paper said it was 1% of chiropractic adjustments, which would be ridiculous, right? We wouldn't be able to get malpractice if that was the case. So that's ridiculous. So it's probably somewhere in between these two numbers. So that's probably a realistic number right there. And maybe people get micro little strokes and they don't even realize that they've had it. They see some stars after an adjustment, or they have a little confusion, and then it doesn't cause any brain damage. But it's probably around that, I would guess. Dr. Sousa actually knows a lot about this. I think he's probably more up right on top of the research. I think he's still doing that. Anyway, so another Smith paper said the risk was 6-fold increase for stroke following chiropractic manipulation again. So, I mean, there's some kind of scary information about it, but I think we have to be careful because in the real world, we don't see it happen that much. Just every now and then you hear about it happening. American Heart Association and Stroke Association, SACO 2014 paper, they issued a statement about cervical manipulation. Most population control studies have found an association between chiropractic manipulation and stroke or vertebral artery dissections, which, I mean, they're really saying, when they say that, they mean double barrels, because the blood clot has been released from the double barrel and the patients have got strokes. The dissection in and of itself isn't going to cause any trouble unless it beaver dams, causes stenosis, or it releases a train of blood clots. But anyway, so patients should be informed of the statistical association between manipulation and cervical dissection prior to undergoing manipulation. I can't remember the quarter. I think it's 6th quarter you'll actually practice doing this. You will actually practice telling a patient. You'll learn how to explain this to a patient. Was it 4th quarter? I think it's CCE, you want to say 4? Anyway, I can't remember. I used to teach that a long time ago. That's Dr. Feinberg's class. You'll learn that in the lab. Dissection types, there's an ischemic type. There's luminar or dissection type. There's the ischemic type. So this is just where you get a beaver dam. There's no double barrel going on, but it causes a beaver dam, as we explained, and you slowly start to get downstream ischemia. This is called a vertebral basilar artery insufficiency. Fancy way of saying the brain's not getting enough blood because of the dissection. That is, the false lumen has so much hematoma in it that it's narrowed the flow of blood. Okay, and you can start getting symptomatic, and you could start to get to the point where you get brain damage from it. Intramural hematoma causes the beaver dam. We saw this already. It's the false lumen. It's intramural hematoma in the false lumen, and super dangerous if a double barrowing occurs, right? If you get a precipitating event and it breaks open, causes double barrowing, there goes that train of clots. Embolism from some upstream source is another cause. Maybe you have AFib and you throw an embolism in the left atria. Remember the pipes. Oh my gosh, here we go. My great heart drawing here. Okay, so left atria. If you have AFib and this is going 500 beats per minute, you start developing some clots because of the non-laminar flow. And that clot could go into the left ventricle. It could go right out the ascending aorta. We'll make it easy. It could go down the second pipe. That's the left common carotid artery. And then it could go from there. It could go into the internal carotid artery. And it can go right up into the noodle. It could go into the circle of Willis. Maybe it gets stuck right there where it splits into the middle and anterior cerebral arteries. So very dangerous, right? But it could also go, let's say it went into this takeoff. So that's the subclavian artery, left subclavian. And then there's the vertebral artery, right? There's that big, remember we saw that in gross 1. There's that big pipe, the left vertebral artery. So you could get the emboli stuck there, and there you'd take out a big chunk of your brain circulation and your spinal cord circulation too. So that's another way. See why you got to know those pipes. We're such sticklers on memorizing the arteries, the pathways. They're like highways. You got to know these pathways to understand these conditions. But yeah, that's how that could work. Hemorrhage, maybe the dissection never beaver dams, but it builds up enough pressure where it just pops the blood vessel and you bleed from the outside. So you can get a bleed or a hemorrhage of that dissection as well. That usually happens in V4. And if it does, you got yourself a subarachnoid hemorrhage, right? And we talked about endothelin and about 50% of mortality if that occurs. These can be really dangerous as well. So that's no good. Making the diagnosis, the gold standard is to order a vertebral artery angiogram. There's new 7 Tesla MRI that is super high resolution. Those are being used. Stanford, USC are the only 2 facilities that have those in the Bay Area that I know of. Cervical MRI, we looked at one of those. They're pretty good as well. Specifically, you do a look at the axial T1 fat suppressed images. Can show these intramural hematoma formations within the dissection. Actually, let's take a look at some of these. So here's just an MRI with contrast, and with fat suppression on, you can see a normal vertebral artery here the blood will be black. All right, and then dried blood and hematoma can look really super white on these things. And so this is no good. This is the blood, luminal blood here. And you can see this is all hematoma. That's a dissection. Hasn't double barreled yet, but that's like a disaster waiting to happen if that double barrels. Right? Look at another one. So here's a bilateral hematoma, bilateral dissection. Right? So this is definitely, you're not going to know this, though. How are you going to know this if you're treating these patients? And that's just a risk that the population assumes. And chiropractors, you do your testing, you auscultate the carotid arteries for bruits. We don't even do George's test anymore because it could cause double barrowing to occur. So if they have headaches, you'll learn as you go through the program what to look for. The neurological signs, nystagmus of the eyes, numbness around the lips, any weird nausea, any weird symptoms like that. Then you wouldn't do a grade 5 manipulation until they're cleared by a neurologist. But I mean, we can't do. There's a lot of radiation involved. This is contrast in people. It's not good. But if they do have some warning symptoms, you might have to order something like this to make sure their vertebral arteries and their internal carotid arteries can withstand a manipulation. I think that's going too far, though. You would just refer to a neurologist. What's the treatment? Well, the treatment is the same as the other dissections. So it depends how bad the clot is. So if they have a clot in the brain, you would use heparin to prevent further clotting. They would eventually go on Coumadin. This would make heparin doesn't dissolve the clot, but it makes it so it doesn't get worse. And the body can naturally dissolve it, right? We learned about the natural history of these clots, of these lodged emboli. They'll go on Xarelto or Coumadin for life because of that. You can't really do thrombolysis up in the brain area. So streptokinase, there's some thrombolytic agents that you can try. Streptokinase is probably the easiest to remember. But yeah, I didn't dig super deep into that because that's kind of beyond our scope. But if it's bad enough, you could try surgery, but of course it's really, really risky, right? The 70% death rates have been reported, so it's a really risky surgery. Complications. I mean, you could get further emboli release from the surgery itself. Surgery is just really, it's not a good thing. Okay, coarctation. Let's see. Of course, I have no idea where we are. Let's see. We started on about 600. I think we can go a little further. Let's talk about coarctation. This is not super hard here. So that's defined as a congenital narrowing of usually the proximal descending aorta, and it usually occurs right after the remnants or this ligamentum arteriosum. Right, that used to be open in embryological days. Remember that, and it scars up into a ligament. So it usually occurs right here. This is something you're born with, and you have a super, super thick tunica media, so thick that it's narrowed the vessel down to sometimes like a little bird beak, and that's can cause trouble, obviously. It's the fourth most considered congenital heart defect because it's a beaver dam. I've seen in about 0.01% of the population, or is the incidence of live births. Prevalence I couldn't find, but I would say it's probably at least double that, probably something like, I'd say 0.08% if I had to guess. Prevalence is always more. These are genetic, familial related. Mom and dad have one, you have to watch out. Here is a CT reconstruction that shows it quite nicely. Right? How any blood is getting through, I won't know. But the initial blood, because it's such an abrupt narrowing, comes spraying out. So you can get almost like an aneurysm type thing here. But then the blood settles down. But can you imagine how the pulses are going to be up here? So how's the pressure going to be up here? High blood pressure up here. How's the pressure here? Low pressure. So how are all the upper extremity pulses going to be? Decreased. How are the lower extremity? No, not decreased. Increased. Right? Higher pressure. Right? All of them. The carotid pulses, the brachial pulse. I guess they teach you a subclavian pulse. That's not in any of the board books, so I'm not worried about that one. But how were the pulses down in the femoral pulse, popliteal pulse, dorsalis pedis, posterior tibial? How are those pulses going to be? They'll be down. So that's the clinical sign of this thing. Super strong bounding pulses almost in the upper extremities with hardly any pulses in the lower extremities. There are associated conditions with this: the Berry aneurysm, patent ductus arteriosus, patent foramen ovale. We'll talk about that either in embryology or in fifth quarter. The bifid aortic valve is always trouble. Always needs to be replaced by the time you get old. And the diagnostic signs, again, lower limb pulses, super diminished, right, because of the beaver dam. Upper limb pulses, super exaggerated because of the beaver dam. Here is a contrast arteriogram. You can see the beaver dam right here. You can see the spray makes a little dilation, and then it goes back to normal. But there's not a lot of blood flow there. AV fistula. Why do I feel like it's time to stop? Do we want to go down this road? 70 slides. Yeah, let's stop it right there. I think seems like that's enough for now. All right, we'll pick this up on Thursday.